So I actually did my BDS in Birmingham, and I qualified in 2001, and followed by my membership at the Royal College. Then finished the diploma in implant dentistry and the advanced certification in bone grafting back in the third cohort of the course in 2003. And then completed my master's in implant dentistry at the University of Leeds. And my thesis was specifically on immediate placement of implants in the aesthetic zone. So I have two clinics, one based in the centre of London in Harley Street, and another one near where I live in Reading. And my practice is purely limited to implant dentistry. So I thought I'd share a quote with you that was very relevant to me in the early stages of my career, because every day and everything that I did in implant dentistry really scared me when I first started. But I think you have to do one thing every day that really scares you, and that mistakes often happen, but they're a good part of learning and your learning curve in dentistry. Now, I know a lot of you are dental students or recent graduates and things like that, and mistakes do happen, but it's important that you can actually learn from them. So I'm going to take you back in time and tell you a little bit about the history of dental implants and how they kind of started. And the main year that they were discovered was 1965. So in 1965, a guy called Prof. Brannemark discovered that titanium and bone cells are able to fuse together. And that was when that discovery of osseointegration was made. Although it was not for kind of many years after that that the first human trials occurred, and it was about 1981 that the first human trials occurred, and we discovered that it had a great application for dentistry, and especially for the replacement of missing or failing teeth. And another significant great was actually 1982, when a chap called Albrechtsen published the success criteria for dental implants. And these were 10 established criteria where many, many clinical studies of today were based on these success criteria to assess how implants had performed. So that was a little bit about the history of dental implants. And now I'm going to share with you a number, or rather a measurement, and that's 3 millimeters. One of my particular interests in when I treat patients is replacing failing teeth. Now, all of you in practice one day will find a patient who needs an upper tooth removed, whether it be by a fracture, periodontal disease, or that patient just wants this tooth out because they're in extreme pain. Always remember this measurement of 3 millimeters when you take out these teeth, or you might be placing a denture in your patient's mouth. The significance of these 3 millimeters means, and this is an interesting data set that I've taken for some clinical evidence by a chap called L. Cha in 2011, when they actually measured the average amount of bone loss that occurs when you take out a front tooth, so a central, a lateral, or a canine. And they discovered that in the first 6 months, it was over 3 millimeters of buccal bone loss that occurred in these teeth. So what does that mean? Why would that be relevant to you guys as general practitioners? Well, the relevance is that if that patient is being offered the option of replacing that tooth with a dental implant, you may end up with someone putting an implant in and it looking a little bit like this. So you've lost that 3 millimeters, literally that 3 millimeters, and if that patient has a visible gum line, then that's going to be quite a significant aesthetic failure for your patient. And for an implantologist to turn around to actually correct this situation or avoid it, it means bone grafting, maybe soft tissue grafting, and a lot of work and a lot of time to correct this situation. So when you do see your patients and they do have a problem with their front teeth at the top, then do think about that figure and refer, and it's the timing of the referral. Refer with the tooth in position if you can, and then we may consider something called immediate placement, which saves a lot of time and hassle. We may get results which are slightly better on the gingival margins with the least amount of fuss for your patients. So that's one of the things that I wanted to kind of emphasize. 90% of my patients, in my cases, are immediately placed implants, and they're loaded with temporary teeth at the same time as we extract the tooth. And I've looked at the evidence, and I've looked at the systematic trials that have been done, and we now have like established 10 years of clinical evidence and certain criteria for actually replacing teeth at the same time as extraction. So that's a really important message, that anything that you're looking at as general dental practitioners, or you're referring and your patients are interested in implants, try to refer with the tooth in. So this comes on to a little bit of a topic that we're going to talk about and briefly touch about, the kind of cases that I kind of deal with. And I don't know if any of you heard of the term terminal dentition or failing dentition, because this is the most likely group of patients that are going to want something fixed in their mouth when their teeth are failing. So this scheme of things that I'm talking about, and as it's called Mission Impossible, I'm going to talk about every mission that you have needs to start with collecting data or information. You need to then plan such cases, implement those cases and that planning, monitor results, compliance and audit. And if you use this cycle for all your cases in dentistry, you can only improve upon your results and improve upon your techniques and get better at what we do. So that's generally the steps that are kind of involved. So we're going to break up my cases into missions. So the first mission, should you choose to accept this, is, and let me introduce you to Mr. J. He's our patient. He's a 43-year-old male. He's an engineer, he doesn't smoke, and he complains to you of loose teeth. So he's got loose teeth, he wants a solution, and he certainly doesn't want dentures. Okay? He refuses any extractions as he's functioning at the moment. The guy's got loose teeth and he's functioning at the moment. So the perio people in the room may turn around and say, well, I can fix that, I'm a perio person. But this is kind of what he presents with, you know, when you take an OPG, he's got fairly severe levels of bone loss here, and as you can see, a lot of the teeth are just waving in the wind. They're sitting in the gingival tissue and they're waving in the wind. So you kind of want to offer this guy a solution. And how do we approach this? Because Mr. J has not seen a dentist ever. He's just come to you. And he's eating and he's functioning. And he's just complaining a bit of food packing. He did pull out one of his teeth himself, which just fell out. So you've got a patient in this situation. Are you going to tell him in general practice, well, do you know what? The ideal treatment plan here is that we're going to take all your teeth out and we're going to give you a set of plastic dentures, and they're going to be great. What is the likelihood Mr. J is going to say, yeah, no problem, Mr. Dentist, just come next week and I'll have them all taken out? So we need to discuss options with Mr. J. So how do we approach this case? Well, your data collection is kind of the main step in any really important or complex case that you're going to do. And that is what you've all been taught or being taught at the moment, that your notes, you know, must be comprehensive. You must take in consideration what his concerns are, what his expectations are. Am I going to see Mr. J in my clinic and am I going to say to him, I'll take all your teeth out and put implants in to replace them next week? That may not happen. So you need to discuss with him and address his concerns. You need to look at his medical history. You need to look at his dental history, his social history. What does he do? You know, how far does he work from your practice? How easy it is for him to get here? Your full extra and intraoral examination. Every single patient that you see for whatever complex treatment, even if you're giving them a denture, you need to go through this, and that's quite important. Skeletal pattern, Bob touched on occlusion and TMJs, periodontal, the lip line, smile line symmetry. You need to observe all of this to make a decision on your treatment. Yeah? So your soft tissues and your TMJ. You need to make a differential diagnosis followed by a definitive diagnosis and treatment plan in phases. Yeah? And I'll talk a little bit about the phases in the future of this talk. Okay, so the special tests that you might do as part of your investigations is you might vitality test some teeth if that was relevant. You might have some complicated medical history, so you might need to do a full blood count. Certainly if we're considering implants as an option for this patient, a full blood count might be relevant. B12, folate levels and everything like that need to be checked out. You might want to write to his GP, seeing what's going on. you might want to take a CT scan if he agrees to one of the options of implant treatment. You may want to do a diagnostic wax-up. Look at this gentleman and see what the teeth are going to eventually look like. So that's the kind of special test that you want to do. So what are the options for Mr. J? So Mr. J, we've looked at, we've collected some data, and the options are, is it clearance, periodontal intervention? Are we going to treat this guy with perio treatment? Is it partial or full dentures? Are we going to keep some of his teeth? Is it implant retained overdentures, which may be an option? Or if it's a fixed prosthesis. So in this particular case, we did take a CT scan. We did discuss the options with Mr. J. We did say that your dentition is doomed, but we can do something for you. But we did this progressively over time. So CT scans, I think, are the future of a lot of dentistry, with sectional scans going on, even for your endos and things like that, that we'll be taking more and more three-dimensional scans. You might be thinking, well, that's a big radiation dose, but the dose is coming down. We are able to take smaller sections of patient's mouth to look at the bone. So here we've used a software known as Implant. We've virtually extracted his teeth, and we've looked at where his inferior dental nerve is, and we've looked at where his mental nerves are. And we've marked the really important structures of his mouth. So in this particular case, before and after, we had placed 8 implants in the lower jaw. And we'd done this in one sitting, in one day. And onto those implants, we used ankylos implants here. We placed a fixed bridge. But we placed it as a temporary while things all healed. Now you notice in the upper arch, we left the teeth in. It's a lot of trauma clearing out someone's entire dentition. And to be doing both arches in one day may be a little bit too extreme, so it's progressive. And selecting your patients is very important for this sort of work. After that, after a period of healing, osseointegration takes 4 months on my patients. That's the time it takes when you put that titanium into bone for those cells to fuse to that titanium and that becomes solid, and that's ready then to put a final bridge on those. So we took some impressions. These things at the top here are called copings. They're screwed into the implants and they triangulate the 3D position to your ceramicist. These are then made by your lab and positioned, and they're called abutments, and they go into your implants, and they will provide the stable cores for your bridge. These are the abutments then screwed into the patient's mouth. This is a lower bridge. The gum lines are not perfect, but no one's seen the gum lines. This is the bridge in position, and this is what we can see. And now this is a solid fixed prosthesis. This is something that he can use every day. It's cleansable and things like that. You might hear a lot of people talk about all-on-4. I never do all-on-4. I'm not a great believer of all-on-4. That's where you use 4 implants and something that looks as if it's been screwed into the jaw. There's no fail-safe with that system. 1 implant goes, you lose the lot. Number 2, one of the requirements I absolutely loathe in implant dentistry is the fact that you have to take an acrylic burr to bone and level it out. You're taking away normal anatomy of the patient for the sake of creating a prosthetic, you know. And therefore, it's a very tricky procedure. So you'll never see any of my cases sitting on 4 implants. I'm not a believer, unfortunately. So with the upper arch, really, we did some periodontal treatment, believe it or not, with ongoing maintenance. We checked how compliant Mr. J would be. We checked the oral hygiene before making that decision sometime later to remove the upper teeth at a separate time. So 2 years later, from here, we've taken him to a complete new upper and lower set of teeth based on dental implants. I'm showing you x-rays here, but I have example cases of the final prosthetics later. We'd broken up the bridge, but I'd not removed that. Now, in this particular case, we used an interesting technique because we avoided sinus lifts on Mr. J, and we just went medially to the sinus wall, and we angled the last 2 implants, which is a perfectly acceptable technique to not further put him under trauma of doing bilateral sinus lifts in this case. So it's conservative. So the main thing to take away from my message is really start with the end in mind with all your cases. Plan your final aims and objectives of your case, and that might be even longer term on how we're going to do that. ensure your patients are compliant, and select your patients. Patient selection is vital, yeah, to the success of anything complex that you may be starting with your patients. You need to agree your expectations with your patients and make sure that you can actually meet those expectations, because some patients are completely balmy out there, and you've got to be cautious with that. And plan long-term with your patients, which is really, really important. I always use the KISS rule for a lot of things in life that I use and a lot of my treatments. Yeah, it's keep it simple, keep it stupid. You know, every single case will be address the disease, remove hopeless teeth, get your patients stable before they move on to that. If you don't do implants, you should be referring to someone who you can work with closely, you know, who will be communicating with you at different stages of your patient's treatment. And so you can do the maintenance ongoing for that patient. When it comes to implant treatment stages, there's several middle stages that we need to think about with implant treatment. The surgical planning, the stents, the implementation, the temporary planning. There's lots of things that go on to the background before we actually enter the stage of doing surgery on a patient. And these are some of the stages that are kind of involved. So I wanted to kind of give you an insight a little bit about implant dentistry and what it kind of entails. And you can see it's kind of the end stage of what dentistry has to offer patients who have teeth of hopeless prognosis. So we all have legal obligations to our patients, and one of the obligations that we have in a duty of care is to explain all the available options to your patients. You know, establish good referral bases if you're not doing implants, or do recognized courses in implants. You may want to start, and some people might say, well, we're not taught that in university. How do we start off? You start with working with your local implantologist who's near you, maybe starting with some restorative protocols yourself, keeping excellent records, and then getting yourself onto an introductory course. So that would be a way of starting. So I'm going to share with you some cases, and we're not going to go through in as much detail as I've just done, because I just kind of gave you the steps and what we kind of do. So let me introduce you to Mr. K. Mr. K is a lovely chap. He flew in from Belfast to see us. He had a great story. He was a 69-year-old retired stuntman, and he was a stuntman for many years. And this guy was rocking around for many years with no teeth. You know, he had dentures. He goes, Doc, I hate these. I just really don't like them. What can you do for me? You know. And he just doesn't like dentists, because all they did over the years is every time he had a problem, they used to remove his teeth, to the point he had very few teeth left. So eventually we went through the whole protocol, we talked to Mr. K, and we did something like this for him. Now, you know, in the upper arch, because he had no teeth, we put 7 implants in. We gave him 14 teeth that he functions with. They're not the prettiest things in the world. In the lower, we kept some of the good teeth. So we do sometimes keep teeth. The abutments were placed on a model. I just want to give you a brief overview of what these abutments look like. And we use a little bit of composite just to cover the screw holes on the abutments, on the soft tissues here. That's the ceramic bridge that was made by our ceramicists. And that's the view from the occlusal of the upper palate. And that's the bridge in position. And the great advantage of this, when you see this, is that the palate's completely clear. You're going to change somebody's entire quality of life from somebody's edentulous, yeah, to a situation where they have fixed teeth, where they can chew, function, and work very well. Not the prettiest gums in the world, not the prettiest teeth or the prettiest ceramic in the world, but for Mr. K, this works. You know, this is a 69-year-old gentleman who had no teeth. Am I going to look at extreme detail? So this is where we took him, from nothing to something where he can smile, he's happy, he's functioning, and it works for Mr. K. And this is how we can change people's lives. And this is what dentistry can do for people using our modern techniques. So your quality of life, your speech, your eating, your functioning, all of that really, really improves, and your taste. Now, you've probably seen denture wearers. Some really get on with their dentures, but this is a different level of quality and function. And if you think about it, implants, as in the body, is one of the only things that you can actually prosthetically replace. A fully functioning body part is a tooth. If you lost an arm, you couldn't replace your arm with a fully functioning arm. If you lost a leg, you couldn't replace the leg fully functioning as it did. But if you lost a tooth, we have the technology to give you a tooth back. It's great stuff. Aseptic protocol. So those of you who love oral surgery and things like that might like what's involved in implant dentistry. Because in implant dentistry, we use an aseptic protocol. We get draped up like surgeons do as if you were doing any operation in the body. We use iodine, we disinfect our patients. And the very observant is my assistant is here today, who is in this picture. Zara, where are you? And so Zara was assisting me in a case in Reading. But this is generally how we operate. I'm fortunate to have a surgical light in my operatory as well, so we need lots of light and shadowing as we're placing things in 3D. So just an insight a little bit to how we kind of do it. So this is our third and final mission, because we've kept this brief, and I'm going to introduce you to another patient, Mr. G. So Mr. G, he's a really funny gentleman. He's an Italian, and he's an entrepreneur, he's a non-smoker, you know, and he just complains that he can't enjoy his food. He doesn't like dentists, and he might occasionally grind. Bob will probably do something with his masters here, which are slightly enlarged. But this guy's been kind of rocking around like this for a long time. And you know, there's a lot of spaces, the gums are stable, but these teeth are rock solid. You know, the last thing I wanted to do with these teeth is actually take them out and give everything based on implants. They're rock solid. You know? So we worked around the options here. And this is kind of a summary of what we did. We placed 10 implants, but we kept a lot of his teeth. And we went very, very conservative with his treatment and the management of his parafunction. We didn't even crown the front teeth. We bonded them. We placed something called Venus Pearl, a lovely composite that some composite junkies will really like. And we used that from a wax up on a model. And by giving him poor posterior support and giving him his back bite back, we were able to build up the front teeth and place implants in ceramic, and he was functional and happy at that, and we'd not destroyed good tooth tissue. So it's almost a conservative smile design that Tiff will talk to you a little bit about later, but using implants to replace what we want. So not a single bridge was placed. We didn't cut into any teeth, because what's the point of doing 10 implants around teeth if you just cut them down anyway to put crowns on them, to make them look pretty? You know? This is what the functional thing is. So this has had no posterior support, you know, really solid front teeth, and implants placed around there. We got rid of that tooth down there. But just an example of what conservative implant dentistry can do with multiple fixtures. Again, not the prettiest, almost aesthetic smile that we did, but functional. And is Mr. G happy? He was extremely delighted by the end result of his treatment, which is the most important thing. You've got him back to functioning, you've got him eating steak, you've got him working, and we've done it in a conservative fashion, you know, and we've kept his teeth, and we've got a more compliant patient. We sometimes meet challenges, and the challenges we sometimes meet in implant dentistry is that, for example, here, we've taken a upper 6 out, and we have very, very little bone. We have a sinus that comes in the way. You know? But again, using techniques of immediate placement, sinus lifting, very conservative sinus lifting from the crestal region now, that's from the socket space, so we're not traumatizing our patients. We're able to place and stabilize an implant at the same time of extraction, even at this level of bone. This is only, so before it would have been block grafts were taken, or we'd come in from the side. Now we're being much more conservative, much more almost microscopic in our approach to this sort of thing. But it all depends on timing of everything. Here you see a thickened sinus lining, and this view is called a cross-sectional view, and this view is from the mesial to the distal of the tooth. So you're looking that way, so you're looking, or buccal lingually as well. So it's kind of giving you, your periapical view will give you a buccal palatal view, but this is a mesial distal view of your tooth. So that's quite relevant when in 3D when you're treating implant patients. So another interesting case. This is a big example of what we do and how immediate placement helps patients. We have a deciduous lateral incisor here, and you've got a failing central incisor, large root canal, post-crown, it's cracked. And we CT scanned this gentleman, looked at his bone, and what I was most interested in where the central incisor actually sits within the socket, and this is the thin buccal plate of wall on the outside here, and our implant actually goes in palatally. But it goes in palatally, but then the head of the implant will still stick out in the right position, if you get it right and know how to do this, within the socket. Now, aesthetically, to get this right, for the immediate placement, that's where your implant head should be, and it should be 1 millimeter behind the line from the cervical margins of these adjacent teeth. If you get it too far forward, you end up with a long tooth. Too far back, it might not hit the occlusion right, and things like that. This is a spot-on measurement. And sometimes, and the harder cases are when you have two implants next to each other, and you're trying to conserve the bone in between, because you want to conserve the papillae there. So this was our temporary. We placed two ankylosing implants next to each other in this place. We placed a temporary using acrylic, and there's just one suture down for the gum in that region. And we augmented, and it's been very well proven that using things like PGRF now improves implant-to-bone contact. We used to again think that the bigger implants, these very tapered implants, were the ideal ones for immediate placement. They're not. It's parallel. The narrower you go, the bigger the buccal space, the better. The bigger the space between your implant and that very thin wall, the better it is, because we augment that space using something called BIOS. And that has proven to have better contact of bone to your implants, and you have better aesthetics for your patients. Papillae. Now, these two little bits of pink are very, very relevant to us, yeah? Because it's very easy to lose them, yeah, on certain patients. So again, bringing back to the point of immediate placement and placing your and replacing your implants at the same time will conserve this. To actually keep these when a tooth is missing, or you've got a thin degree of bone or thin degree of blood supply with these papillae is quite difficult. So I wanted to kind of just explain the importance of keeping normal anatomy for your patients. It's another example of what I do and the kind of patients that approach me with really, really failing teeth, bad perio, lack of bone, being told they need full dentures. Specifically because my interest is in immediate loading, it's giving them teeth in one day, and some of the patients we're developing and grafting bone at the same time. So this is just another case example for you. So as I conclude this talk, I'd just like to say that nothing is impossible, because I like this quote from Audrey Hepburn, because it actually says I'm possible. Yeah? And modern day implant dentistry allows us to treat previously untreatable. And I'd like to dedicate this lecture today to the late Prof. Brannemark, who died late last year, which was just a few weeks ago, because he was the forefather of implants and invented and discovered that titanium links with bone. And one of his great sayings was, no human should have to place their teeth in a glass at night. And this is the fundamentals of what I do in my practice. Thank you very much, and it's been a pleasure talking to you this afternoon, and I look forward to any questions.